Welcome, everybody. We're going to get started in just a moment. Thanks for being here. Okay, we're going to get started because we have a lot to cover today, and this is recorded. So if you missed the first piece, you'll be able to catch it on the recording. But welcome, everyone. Welcome to the Melanoma Research Foundation's Mastering Melanoma Virtual Patient and Caregiver Symposium. My name is Miriam Kadosh. I am the Director of Education and Patient Engagement here at the Melanoma Research Foundation and feel very lucky to be with all of you this evening. We are pleased to have you join us for this wonderful educational opportunity, and we do have a great lineup of speakers tonight who will share about the work that they are doing in the melanoma space, discuss diagnosis, treatment, clinical trials, and answer any questions that you may have. Our mission at the Melanoma Research Foundation is to eradicate melanoma by accelerating research while educating to and advocating for the melanoma community. We know that education is critical for patients to make informed decisions about their care. I'm going to walk you through a little bit of history about the MRF. And pull up my slides here. Opportunities without our wonderful sponsors, so thank you to them. And can you see my screen okay? Okay, and we'll talk a little bit more about the programs that we do as we go forward, but I just want to share a little bit about our history and how we got started. We were started about 27 years ago by Diana Ashby. She was a young adult who was diagnosed with metastatic melanoma, and at that time, there was not a lot of research out there. And so what she decided with her family and friends was that she wanted to be an advocate and to help fund research in a space that there really wasn't. So she enlisted her friends and family and began funding basic cancer research to help make a difference in the lives of others. And she unfortunately passed away, but her legacy lives on. And we're so grateful for her starting our mission, and because of her and because of the wonderful folks in this space, melanoma research has grown, and our mission has changed and evolved with that. So our mission is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. And here's our footprint today. We are located our headquarters are in Washington, D.C., but our footprint is national. A little bit about our research arm of the organization. We fund research, and we have funded $23 million through grant recipients. You can see here on the screen, in 2022, we had 27 grants with more than $1.9 million. We also, I want to mention that everything that we do is patient focused, and we have patients on our review committee for our research grants. So if that is something that you'd be interested in doing, please let us know. And we'd love to get you as part of our peer review committee. Advocacy. We advocate on the state and federal level for the melanoma community. One big piece is we advocate for research funding for melanoma, and with the Department of Defense, with the NCI, with the NIH, but with the DoD, the Department of Defense, melanoma was lumped into other rare cancers, and our patient advocates, really lobbied to have melanoma be its own line item. And after lots of hard work, melanoma got its own line item for $10 million, and then $40 million for melanoma research. So we are really making strides in this space, and also have prevention initiatives with the federal tanning bed ban for children under 18. And so that's a piece of legislation that we've worked really hard on since 2005, actually, to get that passed, to ban federally tanning beds for minors under 18. And then lastly, access. Access is a huge issue. Access to clinical trials for patients, access to telehealth, access to drugs, and then to cancer centers as well. Education is our third pillar, and you all are experiencing an education program right now, this evening, which is just one of the many programs that we put on in for the melanoma community. We have monthly Ask the Expert webinar series where you can log on and hear from an expert about a different topic. And we really want to hear about the topics that are interesting to you: latest treatments, FDA approvals, clinical trials, psychosocial support, and all of that. We also have free educational materials on our website. So if you go to melanoma.org under Educational Institute, you can see all of our educational materials there. We also support our rare subtypes, so be on the lookout for rare melanoma subtype educational information as well. I want to share about our prevention and awareness campaigns, which are pivotal to the work that we do to prevent melanoma and bring awareness to some other rare melanoma subtypes, including mucosal melanoma, ocular melanoma, and pediatric melanoma. So these are our 4 prevention and awareness digital campaigns that you can interact with us on social media and see that this year our hashtag #GetNaked is icon, I guess we call her, is Teddy Mellencamp. She was diagnosed with stage 2A melanoma, and she's a Bravo star, and her father's John Mellencamp, if you know him, a musician. So she's been a huge advocate for the melanoma community, and we thank her for being our Get Naked spokesperson this year. And lastly, I just want to share about one of our educational opportunities. We have animated patient videos on our website. Animated patient videos are 5 to 7 minutes, and they're really on a patient level to help you understand different aspects of melanoma treatment. So our newest one that just came out 2 weeks ago is our new module on clinical trials. So it helps break down what melanoma clinical trials are, hear from experts, and from the patient experience as well. So go on our website and check those out. And you can even scan this QR code here to learn more. Lastly, follow us on social media. I just shared a snippet of the work that we do, but there's a lot more that we do in ways for you to get involved. And I am going to stop sharing for just a moment to share some housekeeping for this Zoom. A bit of housekeeping before we get started. We encourage you to use the Q&A box to ask questions throughout the session. And the information presented during today's session is for educational purposes only, and any specific individual treatment questions that you may have should be directed to your healthcare provider. We encourage you to visit melanoma.org to learn more about the resources that we have available as well. And lastly, this session will be available for viewing after, so if something was said too fast or you want to rewind, you absolutely can. It will be available on our videos on demand library and on YouTube, so you can share it with others if you like. Okay. I am going to introduce our first speaker. Dr. Rebecca Hartman is here with us today, and she is an associate chief of the dermatology section at VA Boston Healthcare System. She's director of melanoma epidemiology at Brigham and Women's Hospital and assistant professor of dermatology at Harvard Medical School. She clinically specializes in care for patients with melanoma and pigmented lesions at Dana-Farber Cancer Institute and practices medical dermatology at VA Boston. In addition, she conducts melanoma epidemiology and clinical research funded by the VA and Department of Defense, focusing on aggressive and rare melanomas. Long day to get all these words out, but Rebecca, Dr. Hartman, we're so glad you're here.
Thanks so much for having me. I'm so excited to be here and talk to you about melanoma prevention and diagnosis. Thank you for the kind introduction. So I'd like to first talk about how we can prevent melanoma. Many of us know that the environmental risk factor most linked to melanoma is sun exposure. There's actually only one randomized trial to support the use of sunscreen to prevent melanoma, something that I recommend every single day in my clinic. But importantly, this study out of Australia, where they recommended daily use of SPF 16 sunscreen, did find a 50% reduction in new primary melanomas. So I think this is pretty strong evidence to support the use of sunscreen to prevent melanoma. And Australia has some really great public health campaigns. There are other things we can do in addition to sunscreen. I always tell my patients sun protection is a team sport. So Australia likes to ask its residents to slip, slop, slap, and slide. So this means slip on a piece of sun protective clothing like a shirt. Clothing can have a label on it called UPF, or ultraviolet protection factor. And this signifies how well the clothing is at blocking the sunlight from hitting your skin. I always tell my patients you can just hold your shirt up to the light in your room, and if the light's coming through, then the shirt is not opaque enough to prevent the sun. So polyester or synthetic fabrics tend to block the sun better than cotton. Slap on sunscreen, here they're saying use SPF 30 or higher. We'll talk about that in a minute. Slap on a hat, seek shade, and slide on sunglasses. So I think none of us are perfect at doing one thing, so trying to do several things will improve the likelihood of you avoiding a sunburn and sun damage that can lead to melanoma. So how should you use sunscreen? So you want to look for a broad spectrum sunscreen, meaning it blocks both UVA and UVB, which are the two types of solar radiation that reach the earth and can damage your skin. You want to use at least SPF 50. So SPF is the sun protection factor. It's determined in a lab, basically looking at how long it takes the skin to burn when a certain amount of the sunscreen is applied. There is some diminishing returns with SPF. So you can see in the chart I have on the right, the red bar is how much sunlight radiation is reaching the skin. So the drop from no SPF to SPF 30 is quite significant, 100% to 3%. But then the difference between SPF 30 and 50 is a lot smaller. So there's some diminishing returns with higher SPF. There's also some concern with high SPF. SPF really just measures UVB protection, so there might not be as good UVA protection. But there actually was one study that found using SPF 100 sunscreen on half the face worked better than SPF 50 sunscreen. The bottom line is I tell my patients at least SPF 30. Often for melanoma patients, I say SPF 50. We think that extra SPF may give you a little bit extra protection if you're not applying it perfectly, which again, none of us are perfect. So moving on to application, the key is really to use a lot of sunscreen. Most people don't use enough. You need to use 2 tablespoons full for exposed areas if you're in a t-shirt or shorts. And then the other key thing that people forget is to reapply. So people think we have our sunscreen on, we're ready to go to the beach for the day, but you need to reapply every 2 hours. And importantly, even water-resistant sunscreen is not resistant to toweling. So it's resistant to getting wet, but most of us towel off after we get wet. So you also need to apply after toweling off. And then many questions that I get about sunscreen, what about using it in the morning or evening? So it is true the UV index, it's strongest in the middle of the day. That really represents UVB. You can still have UVA throughout the whole day. So I recommend, as long as the sun is shining, it's a good time to put on sunscreen. What about on a cloudy day? Clouds actually only block 20% of ultraviolet radiation from hitting the earth. So even on a cloudy day, especially in summer, good idea to use sunscreen if you're out for a long period of time. What about in the shade? So there actually was another interesting study that looked at folks in the beach. They put half in the shade and half they gave sunscreen. And actually the shade group had more sunburn. And the thought is that the sunlight can reflect off the water, off the sand if you're at the beach. So even in the shade, that may not be enough on a sunny day at the beach. And then what about through a window? Most windows actually only block UVB, they don't block UVA. And you can see from this picture that I have here, excuse me, that this is of a truck driver. So half their face has a lot of photo aging and wrinkles because of the UVA from driving in a truck for long periods of time in the sun. So a window is not enough either. So moving on from protection, who gets cutaneous melanoma or melanoma of the skin? There is a variation in who develops melanoma based on race and ethnicity. So it's most common in non-Hispanic whites with a lifetime risk of 1 in 33 people. The risk in Hispanics is 1 in 200, and in Blacks, 1 in 1,000. But it is important to note that melanoma can happen in anyone. And even within these groups, there's a lot of variation because the risk factor we really think is sensitivity of the skin to sun. And race and ethnicity is not a great predictor necessarily of that. But people at highest risk would have fair skin, light eyes or blue eyes, light colored hair. Melanoma risk also increases as we get older, more common in males than females. People who make a lot of moles, whether they're normal appearing or atypical or funny appearing, are also at higher risk of melanoma. Importantly, we now think that most melanomas actually just start as melanoma. They don't come from a mole that's gone bad, but there still is about 30% of melanomas we think that have come from a mole that has transformed and become a cancer. And then having your own history of melanoma or having a first-degree relative with a history of melanoma also increases your risk of getting another cutaneous melanoma. But those risk factors were really just for skin or cutaneous melanoma. Importantly, this does not include rare subtypes like uveal or ocular melanoma, which happens in the eye, mucosal melanoma, which can happen in the mouth, in the genital urinary area, or in the nose, and then acral melanoma, which is on the palms and soles and under the nails, so the hands and feet and under the nails. And really these subtypes, with the exception of the eye melanoma, which is also more common in non-Hispanic whites, the other two subtypes happen evenly across all races and ethnicities, and they tend to carry a worse prognosis. So it's important to also be able to recognize those. So how should we look for cutaneous melanoma on a skin exam, which is kind of what a dermatologist does every day? You may have heard of the ABCDEs, but my favorite way is actually the ugly duckling. There's data that suggests it's better than the ABCDEs, and I like it because it's very intuitive, like a kindergartner could understand it. You're basically looking for something that stands out, that doesn't fit with the rest of the spots on your skin. I talk about the buddy system. So spots that are not dangerous usually have buddies. So the first two pictures on the top show kind of ugly duckling melanomas. So in the first, unfortunately, I can't figure out the pointer. Let's see. I can find it. I don't think I can find the pointer, but I'll do my best to describe. The first picture, the gentleman has many moles on his back, but you can see that there's this much larger, darker lesion over here on his right, the back of his right shoulder. So that's a melanoma. It's an ugly duckling. It sticks out. The second photo is actually one of my patients who was very freckled, didn't have a lot of moles, but she had this larger irregular brown spot that sticks out. So that's what you want to look for when you're looking at your own skin for a melanoma. And then the bottom two photos are benign, not dangerous lesions. The red ones are called cherry angiomas. The brown crusty ones are called seborrheic keratoses. And it's good examples of the buddy system. So you'll often see many of them on the skin, and that's reassuring because it's unusual to have more than one melanoma at once. And then once we suspect melanoma, the diagnosis is made by taking a sample of the skin and looking at it under the microscope in pathology. We can take the sample in different ways. We can do this shave technique, which is like a scoop out of the lesion. We can do a punch biopsy with this cookie cutter device. If we have a really high suspicion for melanoma, we'll just cut it out surgically with stitches. And then I want to help walk you through the pathology report because it has a lot of information in it. So what does this report mean? What are the next steps? What does the future hold when you get a pathology report with melanoma? So the pathology report of melanoma is often very standardized and will include all this information that I'll walk you through. So you'll see the specimen type. This is a skin excision, the site where it was located, and then specific features to melanoma. So the subtypes, which I'll walk you through in a moment. And then the next thing you'll see is the Breslow thickness. And this is how deep in millimeters the tumor is invading into the dermis. So melanocytes or pigment cells normally live in the epidermis, the top layer of the skin. When you have melanoma or a cancer, they can stay in the epidermis. That means in situ, stage 0. Those patients have an excellent prognosis. There's no invasion. And then the thickness goes from there depending on how deep down the tumor is invading. And this is important because this is the single most important prognostic factor for how patients will do, besides whether the tumor has spread in their body. So if the tumor is localized to the skin, the most important prognostic factor is how deep it's gone, not how wide it is. And then we classify thickness into these categories: less than 1 millimeter thin, 1 to 4 millimeters intermediate, more than 4 millimeters is thick. And then I want to talk about the Clark level because patients will often see this and come concerned to our clinic. This is describing basically in the pathology where they're seeing the tumor in terms of how deep it is, but not using the millimeters. So it's not as standardized, and it can really vary depending on where the skin is from, because some skin is more thick, like on your palms or soles. Some skin's very thin, like your eyelids. It's not the same as disease stage. People will become concerned when they see a deep level. And I would just advise, that this is not a key factor in how you're going to do or the treatment. So I would probably try to overlook that because we get a lot of questions about it, but it doesn't really impact what we do. And then ulceration is another important one. So the backbone of tumor staging, how we stage the tumor, is the thickness and the ulceration. So ulceration means whether or not the tumor has eroded the top layer of skin so that it's broken down. And it's a sign of a more aggressive tumor if it is ulcerating or eroding that top layer of skin. So this is just a quick overview of the cutaneous melanoma subtypes. On the top left, superficial spreading. This is the most common subtype of melanoma. Typically, these lesions are brown or multicolored, but I have a picture of a patient who had a pink one because they can rarely be pink. Lentigo maligna is a subtype that tends to happen on the face of older folks with chronic sun damage. Desmoplastic is a rare subtype that tends to be more of a scar or pink. These desmoplastic melanomas can be locally very invasive, but they have a lower risk of spreading elsewhere in the body. And then on the bottom, I have 2 subtypes that tend to be more aggressive. Nodular melanoma grows as a nodule, and the reason why it tends to be more aggressive, it can grow vertically quickly. And I mentioned how the depth is really important. And then acral lentiginous, which happens in the nails, the palms, or soles. There's also some data to suggest that this may be more aggressive, and it also tends to be diagnosed later. So this is from from the literature from which we derive the melanoma staging, looking specifically at localized melanoma, so melanoma only in the skin, and showing how the importance of tumor staging impacts prognosis or how patients do. So you can see here for T1A, which is the earliest Breslow thickness of melanoma, it's less than 0.8 millimeters thick and it's not ulcerated. Patients do really well. And similarly for T1B, they have 98 and 96% 10-year melanoma-specific survival. But as the tumor gets thicker, the prognosis is not quite as good. And I should add that for in situ melanoma patients also, it's not shown on here, but they carry an excellent prognosis as well, approaching 100% survival. And then this chart is showing the different tumor stages of melanoma. So as I mentioned, the categories are really determined by 2 things: the thickness and then whether or not there's ulceration. So a thicker tumor has a higher stage, and then an ulcerated tumor has a higher stage than a tumor that is not ulcerated. What else? What other information can be found in a pathology report? So they'll include the mitotic rate. which indicates how rapidly the melanoma cells are dividing. And it's reported as a number of these dividing cells that are seen in a specified area, square millimeter of the slide. And a higher mitotic rate is associated with more aggressive tumor. The cells are dividing more actively and growing. Satellite metastasis, which are small nests of cells that have broken off from the main tumor, and they'll indicate if that's seen or not. If that's seen, that is also a sign of a more aggressive tumor, is showing signs of spreading in the skin. Tumor infiltrating lymphocytes or TILs. This is not always reported, but what they're looking at is the immune system, the presence of your white blood cells or immune system in the pathology specimen. And if they comment on it, they'll say whether it's absent or there are no white blood cells. They'll say non-brisk, which is like a small amount of white blood cells, or brisk, meaning there are a lot of white blood cells in the tumor. And having more white blood cells in the tumor is also associated with a better prognosis, because this means the person's immune system is reacting to the tumor and trying to attack it. And then regression means that there are signs that the tumor was there but has been replaced with some scar. And this is also a sign of the immune response, because the immune system is attacking the melanoma and basically clearing it from a part of the tumor. And they'll indicate if that's present or absent. And again, this is from our staging system, just showing how some of these features can impact prognosis. So the first graph is mitotic rate. And you can see here, if there's 0 or 1 mitoses, the prognosis is very good, 10-year 97 or 96% survival. But as the number of mitoses increase, if there are more than 4 or 11 plus, the prognosis worsens because the tumor is so active and rapidly dividing. And and then similarly on the bottom right, having any satellite lesions upstages the tumor and is associated with a worse prognosis. There are just a few more things to comment on the pathology report. So they'll note lymphovascular invasion. This indicates if the tumor is invading blood cells or lymphatic ducts in the skin. They will report this as present or absent. That is also, if the tumor is doing that and invading those structures, that is a more aggressive tumor. Similarly, perineural invasion, indicating if the tumor is invading or surrounding nerves in the skin, and they'll comment if that's present or absent. If present, that's associated with a more aggressive tumor. And then, as I mentioned, we think now most melanomas start de novo, meaning they come from normal skin that just starts out bad as a melanoma tumor. But they will indicate if there was a pre-existing mole, because a subset of melanomas do come from a mole that has transformed into a melanoma. So a mole is a benign growth of your melanocytes, and a melanoma is a cancerous growth of the melanocytes. And then they also make comment on the growth phase, and that means where they see the tumor growing. A radial growth phase means it's growing horizontally, as often seen in superficial spreading melanoma, and a vertical growth phase means it's growing downwards or deeper, as can be seen in nodular melanoma. And so we talked about so most cancers are staged with this TNM system, T for tumor, N for nodes, M for metastasis. So we talked about the T staging, the tumor staging for melanoma. The TNM, each category gets its own staging, and that's combined into Roman numeral staging. So using the Roman numeral staging, stage 0 or stage 1 melanoma, stage 0 being in situ, stage 1 being the earliest stage of melanoma. For in situ melanoma, the cancer cells are just in the epidermis, the top layer of skin. They haven't spread at all into the dermis. And then for stage 1, they've spread very little into the dermis, not very deep. Then for stage 2 melanoma, again, this is based on the T staging system. So if the lesion is ulcerated and at least a millimeter, it can be stage 2, or if it's not ulcerated but deeper. And then as my colleagues who treat advanced melanoma will talk about management of stage 3 melanoma, but this is when the melanoma has spread to a lymph node. And stage 4 melanoma, when the melanoma has spread to distant sites. So what's next? What's the future of melanoma diagnosis? I am sure I will have a lot more to talk about in the next several years about this, but In dermatology, there's a lot of excitement using total body photography and artificial intelligence to assist in the diagnosis of cutaneous melanoma. These studies are already being conducted and underway, preliminary studies. I think the key thing is we need to figure out how to integrate these technologies into our practice and make sure that they've been appropriately examined to look at the risks and benefits of using them. But I do think that this is on the horizon very soon and has the benefit to really help patients improve diagnosis. And then something that is already happening, but in general, the consensus from at least the dermatologist melanoma experts that I talk to is that we need a little bit more data, is using molecular techniques to determine prognosis. So you may have heard of some of these tests. There are several different companies that will look at molecular expression of certain genes from pathology slides and use that to categorize how patients are going to do. The problem is we haven't really looked at these in a prospective way, meaning we haven't kind of looked at how people do when this happens going forward. And we don't really know how this testing impacts our management, how this should affect how we image someone or whether we treat them differently. So until those studies are done, it's a little bit hard to know what to do with this information. But I do think those studies are going to be done and some of them are actively being done. And so this is something on the horizon as well within the next few years that may impact how we practice. And so with that, I'd just like to thank you so much for your time and attention for the kind invitation to speak today.
Thank you so much, Dr. Hartman. The first question I have for you is, you did a great job of kind of explaining the pathology report. And for a patient who may not understand kind of what those terms are or what that means for them, what would you say would be the first few questions that they should ask their care team provider?
Yeah, that's a great question. Certainly with our new patient visits, we spend most of the visit kind of drawing the skin diagram and explaining the pathology. I think, key questions would be to understand what is your stage. So from the skin specimen, that would be really the thickness and the ulceration, and how that impacts your prognosis. So again, an early stage tumor has a really excellent prognosis. And I think as a patient, if I had that, I'd want to know that to understand kind of where you fall. And alternatively, a later stage tumor that may carry a more severe prognosis, I'd want to know about that too, to understand kind of next steps and what to expect. So I think the most helpful thing is to try and I guess understand where you fall within those categories in terms of staging, and B, what is a real explanation of that. So as I mentioned, T1A melanoma has 98% 10-year survival. So I tell my patients with that to wear a seatbelt, exercise, and eat broccoli because they may have other things going on in their life that threatens their health. And I think it's really important for those patients to know that because they come to us as a cancer center, understandably, incredibly worried about their diagnosis. So, everyone falls into a different category and has a different prognosis. I think it's important just to understand where you fall within that so that you really understand your disease and what it means for your health.
Yeah, thank you. And we do have a patient guide that kind of walks through all of those things as well. So if patients are looking for that, we have it available and we can send that to you, or it's available online. And then a question that we always like to ask and we always get is, what sunscreen do you recommend?
Oh, this is a great question. I could have done a whole talk on sunscreen, but I restrained myself. So it's interesting. So again, I recommend broad spectrum. I recommend at least SPF 30. And in general, for my melanoma patients, I say at least SPF 50, just because even though the SPF has diminishing returns, there's some thought a higher SPF will make up for improper application. And then there's a lot of questions I get about what ingredient in the sunscreen. So the FDA actually did a couple of studies within the past few years, I think starting in 2020, where they applied really large amounts of sunscreen to people for several days and followed them. And they actually saw that some of the ingredients in the sunscreen were absorbed in the blood. They didn't necessarily see any harms from that, but the previous thought was that it wouldn't be absorbed. Again, this is not realistic because they put on so much sunscreen and kept these people like in a room for a week putting on sunscreen. But so now there's some question about the safety of different ingredients. So for my patients that are very concerned about potential exposures to the sunscreen, I'll often recommend a mineral-based sunscreen like zinc or titanium because that's broad spectrum, not felt to be absorbed. Even the nanoparticles, there's animal model data to suggest that the nanoparticles are not absorbed through the skin. Um, the problem is some of the other ingredients are actually really helpful because the zinc and titanium tends to go on with like a white sheen, might not be as friendly to patients with darker skin tones. So what the FDA has really asked for is just more data because we don't know any potential harms or not. We just know that they're absorbed, so we need more data. So that's kind of the current state of sunscreen. I think it's going to take many years to get more information in terms of that more data category from the sunscreen companies. So if you're very, I mean, more, any sunscreen is better than no sunscreen. I say use the sunscreen that you're going to use. So if that's a spray sunscreen, then use that. I tell patients when using a spray sunscreen to make sure they're not inhaling it to hold their breath. But I think whatever sunscreen you're going to use is the right sunscreen for you, and just make sure to put it on every day when you're outside and to reapply often.
Yeah, thank you so much. It can definitely be overwhelming in the sunscreen aisle, and I'm sure patients tell you that all the time. They look at all these different bottles and sprays and kind of don't know where to turn. So I appreciate you sharing that information with us today. And thank you for being here.
Great. Thank you so
Those
much
are
for having me. My
all.
pleasure.
Yeah. Okay, great. So now we're going to move to our next speaker. We have Dr. Tara Mitchell here with us today. Thank you for being here. Dr. Tara Mitchell is an associate professor of medicine at the University of Pennsylvania's Perelman School of Medicine. She's the section chief of melanoma sarcoma in the Division of Hematology and Oncology at Penn's Abramson Cancer Center and the director of clinical research for the Tara Miller Melanoma Center at Penn. Dr. Mitchell is a board certified in both medical oncology and clinical pharmacology. Welcome, Dr. Mitchell.
Hi, thank you for the invitation. Today I'll be speaking about therapies for melanoma. So I look forward to questions at the end, and there have been quite a few advances to share. I'll start by talking about the concept of adjuvant therapy. So Dr. Hartman did a great overview of the melanoma diagnosis, and that's usually followed by the surgery, which many of you have had to remove the melanoma and sometimes the lymph nodes. And then she also outlined a lot about the staging and how important it is to be aware of your stage, because that really determines what your risk of this melanoma coming back in the same place or spreading to another part of the body, becoming a higher stage or stage 4, what we call metastatic disease. The purpose of adjuvant therapy is a treatment, a medicine, which can be a pill or an infusion that's given after a surgical removal of cancer with the hope of increasing the chance of staying cancer-free or lowering the chance that the cancer will come back. And so that's kind of what the definition of adjuvant therapy is. It's a systemic therapy given after curative intent cancer surgery in a situation where we know the risk is very high. Excuse me. In our institution, going back to Dr. Hartman's, message about the importance of knowing your stage, in our institution, all patients with stage 2B, 2C, or 3, or higher melanoma are referred to and seen by medical oncology because there are adjuvant therapy options available to discuss. And I'll go over some of those options and the decision-making of who should be treated and what are the pros and cons of treatment. But it starts with knowing your stage and seeking a medical oncology opinion and discussion if your stage is 2B melanoma or above. In adjuvant therapy for stage 2 and 3, there are actually 3 approved options that are in use. One of them is a 2-drug regimen that is taken orally, or 2-pill regimen called dabrafenib and trametinib are the 2 drugs, and that's only for BRAF mutant stage 3 melanoma. In patients with stage 3 and 4, we test all melanomas for a mutation called BRAF. It has nothing to do with your genes or your DNA, and it's nothing hereditary in your family, your parents, your children, or your siblings, but your cancer has its own DNA. And in that DNA, sometimes the gene called BRAF is mutated mutated that causes cancer cells to grow and is what we call a driver mutation that results in melanoma in about half of our melanomas. And so in those patients that have that mutation, this pill regimen is a great option in patients considering adjuvant therapy. The other two drugs that are approved in current use are nivolumab and pembrolizumab, both of which are IV infusions that are given through the IV every several weeks to patients, and can be approved for either stage 2B, C, or 3 melanoma that's been resected with curative intent. Those drugs work on the immune system. So those are called immunotherapies, meaning they work the same way that your, white blood cells, in particular, the T cells, also called the lymphocytes, the same way that those cells can kill viruses, they can also kill tumor cells. But the tumor sort of sends out a signal that puts a damper on the immune response to cancer. And so by blocking that signal, which is called PD-1, so by blocking the PD-1 receptor on the T cell, the thought is that the drug can reactivate our immune system to be more effective at finding and killing cancer cells that may be residual after your surgery and may be floating around in your bloodstream, and maybe one way in which cancer finds a way to come back or grow or spread even after the best, most expert surgery. So as I mentioned, this type of therapy is now approved for stage 2B and C, in addition to patients with stage 3, for which it's been approved for many years. And the treatment is not given forever. It's given for up to 1 year, but we're very quick to stop sooner for our unacceptable toxicity. And I'll talk more about that, but it's very important to know that by no means does anyone have to finish the year to get the benefit if there's some unacceptable toxicity happening. The decision of whether to use the therapy or not in every patient with stage 2B, C, or 3 is a very complex discussion between the patient and the oncologist about the risk of the cancer coming back. So knowing your stage and risk is the start of the conversation. The potential benefit of these drugs in lowering your risk, and also what's the risk of the drug causing toxicity, and I'll review some of that. So it's a shared decision-making between the patient and the care team. I never think of it as a strict recommendation. It's always a discussion and weighing the personal preferences and goals of the patient in avoiding toxicity and risk of the treatment and coping with and managing the risk of the cancer. So close observation alone, meaning checkups with your dermatologist or oncologist, sometimes with CAT scans in high-risk patients, remains an equally reasonable option for all patients, given that there's no long-term data saying that absolutely doing adjuvant therapy saves more lives and results in more patients being alive and cancer-free in 5 years or 10 years. While it does lower the risk of cancer recurrence in the short term by about 20% with any of these therapies, there is a risk of severe, permanent, or life-threatening toxicity. So it's a careful discussion about personal level of cancer risk and risk of therapy. Okay, so how do we decide then? How do we weigh this careful discussion of risk and benefit? So it starts with what's the risk of cancer recurrence and knowing your stage. So in low risk, there's no treatment, and observation alone is the most reasonable option. Checkups, skin exams, and monitoring for any signs or symptoms of recurrence, which you would discuss with your dermatologist or your oncologist. In higher risk patients, we can consider either treatment or observation. The risks of adjuvant therapy are side effects. I would say 85% of patients are going to get through the year with either no side effects or very mild or medium manageable side effects. But there's that 15% who will have more serious side effects, which are manageable, and then the extremely rare or less than 1% chance of a life-threatening serious toxicity or permanent toxicities, which are also manageable. There's also the time and cost spent traveling to visits and at visits, which is an every 4 to 6 week regimen of visits, labs, doctor's visits, infusions. And what's the potential benefit? Well, there's an improved chance of staying cancer-free. So large clinical trials, which are what we call randomized trials, in which patients were assigned to either treatment or observation, have shown that in patients who took these therapies, there was approximately 20% lower risk of cancer recurrence. However, In the long term, we don't know if that translates into more patients being alive and well. And that's because the treatments are also so effective when it does come back, so that the other option is to watch and wait. And when the cancer does come back or become stage 4, then there's been a tremendous amount of progress there too. Treatments are highly effective, and many patients now are cured even with stage 4 and remain cancer-free after stopping therapy. So that's the missing piece of information. We don't have long-term data confirming that treating early in everyone is better than treating some patients only with a time of recurrence. So those are the considerations. We know that it reduces the chance of recurrence, and certainly there's a value in having a lower chance of ever being told that you have stage 4, which is a serious conversation to hear the news that you have stage 4 melanoma or that it's spread to other parts of your body. There's no guarantee of a cure or that treatment would work at that point, but we remain very hopeful that many patients do well, including complete elimination of cancer and long-term cancer-free survival. And that's improving continuously with more and more advances in therapy. The other thing is we don't know which patients are benefiting. We know from the studies, on average, 20% of patients were benefiting, but we don't know if the treatment is benefiting you as an individual, meaning you could have been cured with surgery alone, and then you opt for the treatment and it's not really doing anything for you. It may be that your cancer is determined to come back either way, and it's not going to be responsive to the treatment, in which case it's also not helpful. Or you could be in that 20% in which the cancer treatment was definitely what made the difference in whether or not your cancer came back, but we won't know about that. And so we still need to monitor patients closely for recurrence, including imaging in some of the higher risk patients. So what about the treatment of advanced melanoma? So this is when melanoma comes back. Of course, when it first comes back, if it's in the same place of your original surgery, we first ask the question, can it be removed with surgery? Or if it's in the regional neighboring lymph nodes, but hasn't moved further, we talk about local therapy with surgery. And you can see there on the bullet point, local therapy is still, an aggressive way to treat cancer when it comes back in one site of the body. Otherwise, in some patients when we meet, there unfortunately is not an opportunity for a guarantee of a cure with surgery or removing the tumor, because the tumor is more widespread and involving many sites in the lungs, liver, bone, or brain, which are common sites of metastasis in melanoma. And so we always ask, is there a clinical trial? So looking for a center of advanced melanoma expertise, a center that has clinical trials is going to be really important in your first line of therapy. There are many approved regimens, which I'll go over, but none of them are a guarantee of a cure. So seeking a second opinion, there's no rush to start therapy. In most cases, if you are able to get an opinion at a site with clinical trials, that may be valuable for your peace of mind to know that the treatment being offered to you at your cancer center is appropriate. Or are there other options, such as clinical trials, which may be aiming to improve on the standard options that are available? So these generally, when I meet a patient with advanced melanoma, I talk to them again about these two categories you heard of, either immunotherapy, which, as I explained, works on your own immune system to turn on your immune system to make it more effective at killing and eliminating cancer cells, or targeted therapy, in the select patients who have this activating BRAF mutation in their melanoma, can be highly effective in targeting BRAF mutant melanoma and helping patients live longer, and patients with BRAF mutant melanoma. I mentioned local therapy with surgery. Sometimes when there's limited sites of disease, we use radiation as well to eliminate cancer, which can be highly effective if a person, say, has just one or two or an isolated lung lesion or liver lesion and some reason to avoid systemic therapy due to toxicity or frailty. Then radiation is also used in the case of, patients who come to us where there's an extremely painful site in the bone, or, certain types of lesions in the brain that need to be treated with local therapy, such as radiation or surgery. There's also a drug that's unique called an oncolytic viral therapy, in which immunotherapy can be injected directly into the tumor. So in some patients, melanoma comes back at the site of surgery, but instead of just one nodule that can be easily removed with surgery, the recurrence is multifocal. So it's a diffuse area of lumps and bumps all around the surgical site, which would be too big of an area to resect surgically. And even if we did remove it all, how do we know that there's not more under the surface, given the pattern? And in those patients, this intratumoral injection therapy can be very helpful and is something we use commonly in our practice. And then we still use chemotherapy. We put it lower on the list because years of research have shown that BRAF targeted therapy and immunotherapy are more effective in long-term control of melanoma. But there, of course, we're not curing all patients yet. That's why we encourage clinical trials first. And in patients in which immunotherapy or targeted therapy are not effective, chemotherapy can be very effective with a low risk of predictable side effects that are manageable. So I'll start by talking about what we call dual checkpoint blockade. That's a 2-drug immunotherapy that blocks that checkpoint that I mentioned called PD-1, that receptor on the T cell that blocks the immune system from being active against cancer. So if you now block that checkpoint, the cancer cell can now be susceptible to being killed by the immunotherapy induced immune response in the body. So that's the way that we hope it works. Of course, it doesn't work in everybody, but we have a really long-term follow-up from clinical trials that were started over a decade now, that using the 2-drug regimen is a highly effective way of shrinking and even eliminating melanoma in a large number of patients with advanced disease. And that certainly improves outcomes compared to using the single drug ipilimumab, which was the first immune therapy that was approved in 2011. And certainly we don't use that drug alone anymore, but in combination, this has made a huge amount of progress in patients with advanced melanoma. Similarly, using the single PD-1 blocking drug, so pembrolizumab or nivolumab alone without that other drug, ipilimumab, which blocks another checkpoint called CTLA-4, also, we have very long-term follow-up now. We've been using these drugs for over 10 years, since 2010, 2011. And so we have patients now who got the very first doses of these drugs after bravely volunteering for clinical trials. The tumor disappeared completely and patients remain cancer-free going on 10 years now with any of these regimens, either the single agent PD-1 blocking drugs or the 2-drug regimen that I showed you of ipilimumab and nivolumab. More recently, we now have a new combination, another checkpoint on the immune system called LAG-3 can also be targeted with a drug called relatlimab in combination of the PD-1 blocking drug nivolumab. And this new drug is also approved now for patients with advanced melanoma. So more options is always better for patients and better for care. But with the advent of more and more therapies, what we really need is to develop better biomarkers to determine which patient are likely to benefit from which of these components. Right now, we don't have a great biomarker that says you need these 2 drugs or those 2 drugs, or your tumor is going to do beautifully with just one drug. And we don't need to, add the increased toxicity that comes with the 2-drug regimens that I've showed you. I wanted to share a special slide about brain metastasis, because as you know, melanoma is one of the cancer types that most commonly spreads to the brain. And what we've seen in recent years, and we have at least 5 years of follow-up now in the patients who bravely volunteered for this study, which was called the Checkmate 204 study, 94 patients, they volunteered to get the drug combination ipilimumab and nivolumab without any local therapy for their brain metastasis. So as I told you, when tumors in the brain become large, we treat them with surgery or with radiation. And it used to be that we treated everyone with spot treatment of radiation. In this study, we said, can you just use the immunotherapy? If it's so effective in the body, can it be effective in the brain? And it turns out it's equally effective in the body and the brain. And in over half of these patients, the tumor shrank dramatically in the brain without any radiation or surgery. And complete response, meaning elimination of the tumor that could no longer be seen, was observed in 26% of the patients, so more than a quarter of the patients. And these were long-term responses. So meaning patients can then stop therapy and remain cancer-free in the body and the brain long-term. And we've been comfortable to even say to patients, you may be cured of this melanoma. We're still going to watch you, but you could be cured. And so that's been a huge progress in the treatment of brain metastasis. But we still, of course, have a large percent of patients that are not responsive. And so that's why, again, clinical trials are so important. And getting to clinical trials up front is really where we think they can make the biggest impact in care. Here's a slide that shows that patients can do well and be treatment-free. So as I mentioned, in patients who have a complete response or an excellent response, treatment can be stopped. And the biggest part of the pie here in the dark blue in the left and in the middle, either with the combination regimen or the single agent on this trial, are the the 3/4 of patients who are actually treatment-free long-term after treatment with these drugs, because the cancer was so well controlled that they could stop therapy. So we see larger and larger percentage of patients with the combination and with the PD-1 blocking drugs that are cancer-free after stopping therapy. This is a topic that should be discussed with all patients who have a complete response, meaning if the scan shows 2 scans in a row where there's no cancer remaining, these patients have a very high chance of remaining cancer-free long-term after stopping treatment. A small percentage of patients will have a recurrence after stopping, but many can regain a response by resuming therapy. And so patients need to be continued to be monitored with scans even after stopping therapy. Move on to the BRAF targeted therapy. So there are 3 effective therapies that are available. As I mentioned, the dabrafenib and trametinib, which is also approved in the adjuvant setting after surgery, and then vemurafenib, cobimetinib, and encorafenib, benimetinib. These are all combinations of a BRAF inhibitor and a MEK inhibitor that have substantially improved survival and outcomes in cancer control in patients with advanced melanoma with a BRAF mutation. They have slightly different side effects and ways of taking them, but all of them have demonstrated a clear improvement in patient survival with melanoma and have made huge progress in the field. So then in a patient with BRAF mutation, how do we know whether to start immunotherapy first or targeted therapy first? It used to be that we didn't know, and it was really an individualized discussion with the patient and doctor. What we've learned recently in a trial, again, from patients who bravely volunteered, who had a BRAF mutation, they were randomized or randomly assigned to receive either the immunotherapy combination, ipilimumab, nivolumab first, or the dabrafenib, trametinib, and only if and when their cancer grew or progressed, they would switch to the other. And in this study, for the first time, we saw that patients actually did better if they had immunotherapy first. So we always try for immunotherapy first, but it is still patient dependent. In select patients, depending on the circumstances and how the patients feel, and the shared decision-making with the doctor, targeted therapy can still be used first. Last couple of slides are on monitoring the toxicity, and I can't stress enough the importance of communication with your care team. So patients should be seen and evaluated, including laboratory evaluation before every dose of treatment by either your doctor, your nurse practitioner, your PA. Someone on your care team should be checking in with you and seeing you to make sure that you're not having any severe toxicity. You should also know how to contact your care team during the night and weekend hours, and they should be easy to reach at any time that you may be having severe toxicity on these immunotherapies in particular, but on targeted therapy as well. And then, as I mentioned earlier, the decision to continue or stop treatment can be discussed at each visit and really depends on how the patient is feeling, lab results, toxicity, and the tumor response. If, as I mentioned, there's a great response, there can be a consideration of stopping tumor treatment. The most common toxicities with these are mild and manageable, including rash, itching, and joint pains. Some of the toxicities are very manageable, but are permanent, including a drop in your thyroid function that can be replaced with thyroid hormone replacement, drop in your adrenal gland production of cortisol, which can be replaced with hydrocortisone, or diabetes in 1% to 2% of patients on these treatments. And then, of course, there are life-threatening toxicities, which occur in less than 1%, more like in the 1 in 1,000 risk of heart failure, lung failure, bone marrow failure, or really any organ failure in the body. And that's why the importance of communication and evaluation before every dose, I can't stress enough, so that your doctor knows what's happening at all times. The future directions, which I think are most promising right now, are T-cell therapies. I think you're going to hear a lot about T-cell therapies in clinical trials, possibly even approved T-cell therapies for melanoma. This is where we actually remove surgically a tumor from your body, harvest the T cells out of it, and then grow them up in a lab to make them super active against the cancer. And then the T cells get infused back into your vein. So instead of a drug being infused in, your own cancer-fighting T cells are infused back in, and that is your treatment, along with a regimen sometimes of other immunotherapies or chemotherapies. Some of the newer trials are even looking at taking the T cells out from a blood draw. So even without cancer surgery, harvesting those T cells that may have the power to kill cancer cells, but may need the extra boost in the lab. And so in addition to T cell therapies, we may have seen in the news the advances in personal vaccine therapies, and those are in clinical trials, and then novel combination immunotherapies. All of these hold great promises, and I'm sure there will be more approved drugs that are available to treat and cure more patients in the very near future. To summarize, the advances in systemic therapy continue to improve results in patients with advanced melanoma. Adjuvant therapy reduces the risk of recurrence in stage 2B and C and 3 melanoma, but there's no confirmed long-term survival benefit. So observation remains a reasonable option, and it's a shared decision-making with patient and doctor about who gets adjuvant therapy. And certainly ongoing trials will further improve the treatment results in patients with advanced melanoma. Thank you.
Thank you so much, Dr. Mitchell. You packed a lot in to your short allotted time, so I really appreciate that, and our patients appreciate that too. I have two questions for you. One is, with the toxicity with immunotherapy, a lot of patients ask about quality of life. How do you maintain quality of life through these tough systemic treatments?
I think that's where I can't emphasize enough communication. First of all, the decision and the shared decision making and understanding the risk. But once you've decided that immunotherapy is right for you, the communication with your care team has to be seamless and continuous, not just at the visits, but if in between visits you're having a setback, severe joint pain, swelling, confusion, fogginess, short of breath, cough, fever, nausea, any of that should be an immediate call to your doctor, both for quality of life, because usually your doctor can get you feeling better almost instantaneously with tips over the phone, over the counter management, a quick lab test that they would call in, or a prescription. But more importantly, because if this is the start of a severe or life-threatening toxicity, to be managed appropriately. So I think communication, and then remembering that treatment can be stopped. A lot of patients think if I stop the treatment, my cancer will come back. In melanoma, it's been proven over and over again that that's not true. And only you and your doctor can make that decision about the appropriateness of stopping therapy, even in the face of stage 4, with severe toxicity. Sometimes we have to take a break or even stop, and that we can trust that the treatment can still be effective, even after just 1 or 2 doses. In some patients, 10 years later, they can remain cancer-free. So I think those are the key questions about quality of life on immunotherapy: communication, and when is it time to stop?
Thank you. And you mentioned also a pause, so that's possible too, not just stopping fully
Yes,
outright.
sometimes the
But
pause is appropriate. Depends on the toxicity and the severity of the toxicity and which drug it was due to. Sometimes a pause and recovery is appropriate. Sometimes complete discontinuation is the only path that's appropriate.
Thank you. And the last question is, Dr. Hartman talked about AI, artificial intelligence, and I'm curious if there's any talk about AI for future of systemic therapies, of using AI in any sort of ways.
I think that's such a great question. I think where I could envision it first is helping match up patients with clinical trials. So getting the right patient to the right treatment, using AI to kind of enhance patient education and clinical trials. I think that's where the first area of progress with AI and treatment will be. And I'm sure we'll see that there will be smarter and smarter ways to identify clinical trials and participation for patients.
Yeah, that would be very cool. I do want to say a quick plug for our clinical trial finder on the MRF website. We have a great program where you can be matched with a navigator, not AI, but a navigator, a real life person that can help you navigate through the clinical trial process. Okay, I think that was all of the questions we had for you. So thank you so much, Dr. Mitchell. We're going to move on to our next speaker. Thank you all for sticking around with us. Thank you, Dr. Sondak, for being here. Dr. Sondak is chair of the Department of Cutaneous Oncology at Moffitt Cancer Center in Tampa, Florida. He holds the Richard M. Schulze Family Foundation Distinguished Endowed Chair in Cutaneous Oncology. Dr. Sondak has been a leader in studies of surgical treatment of melanoma and other cutaneous malignancies, particularly the application of sentinel lymph node biopsy and lymph node dissection to the staging and treatment of melanoma, and has been instrumental in mentoring and training many surgeons in these techniques over the years. He has a strong research background. His research interests include surgical treatment of melanoma in adults and children, adjuvant, postoperative, and neoadjuvant preoperative therapy of melanoma, and evaluation of new therapies for localized or disseminated melanoma. Dr. Sondak, I'm going to turn it over to you.
Thank you very much. You seeing my screen okay?
All good.
Good. These are my disclosures. Okay, and the first thing I want to disclose is that melanoma is a huge problem and it's getting bigger all the time. We are busier than we've ever been. It seems like almost every week we're setting a record for the number of patients we're seeing in our clinic. And this study from a few years ago warned us that this would be the case. This study said that looking at all the major types of cancer in the United States, what would happen if nothing changed compared to the way things have been going over the last few decades, meaning nobody changed their behavior about going out in the sun or using tanning beds or wearing sunscreen, etc. Then by 2040, which is only next month, will be only 16 years away, melanoma will be the second most common major form of cancer, with more than double the number of cases that are there today. And since other cancers are on the downslope, like lung cancer, this means that not only will it be the second most common in the US, but it will be the #1 most common cancer in men. Now, there's still time for us to get everybody to stop using tanning beds and doing things like that, and maybe we can turn this around. But even so, we can't undo all the ultraviolet exposure people have already had. We're going to keep seeing more and more and more patients. What can we do, as you've already heard about? We can try to find them earlier. We can try to get this taken care of when it's the most treatable. So how do we treat it, and what's the treatment? Most of what we do is surgical treatment. That's still the #1 standard of care treatment for melanoma. And what's the paradigm? What are we trying to do with surgery? Well, most of the time we're trying to get rid of the primary site, what we call a wide excision, and test whether or not the melanoma has spread to the lymph nodes in a sentinel node biopsy. That way, if this patient is high risk, why, we can send them to Dr. Mitchell or one of her colleagues around the country for consideration of adjuvant therapy. And if it recurs, well, then we can look into other treatments. But today, our goal as surgeons is to try to achieve the highest survival rate. And we've also got a new goal to try to perform the fewest number of lymph node dissections. There used to be a time when almost every melanoma patient got all their lymph nodes removed. Then they went to getting only a very small percentage. And now, then for a while we were in between, but we're still trying to decrease the number of lymph node dissections without letting the disease get out of control. So how do we do all that? And how does that actually work? Well, first of all, we start with a wide excision. What does that mean? It means we don't just remove what we can see, we measure out and take an additional margin of safety around every melanoma that we remove. And for most melanomas that we see, the ones that are on the thinner side, 2 millimeters thick or thinner, a margin of 1 centimeter, that's a little bit less than ½ an inch of normal skin, is taken around the melanoma. Now, since even if we took a perfect circle of 1 centimeter around the melanoma, you can't really sew a perfect circle together very easily. So we'd either put skin grafts on all of them, or more commonly, what we do is ellipse this out, lengthen the length of it compared to the width, so we can close in a straight line with stitches. For thicker melanomas, we are currently taking a bigger margin, 2 centimeters, which even with some of those techniques increases the chance of needing a skin graft or something more complicated. And so a big question is, does everybody really need those wider margins if they have a thick melanoma? This is a frontier area. This is something that is currently being tested in a major international clinical trial, where patients with melanomas that are on the thicker side, who would qualify for a 2 centimeter margin of excision, are randomized. Half of them get that standard approach, half of them get the 1 centimeter margin that is the same as a thinner melanoma, to see if it really makes a big difference. I'm not sure that this trial will show that it is better to take a 1 centimeter margin. We're going to have to see. I am sure that it will take a long time. It's planned that this trial will take 10 years and several thousand patients to get us an answer. So for the time being, we're relatively stuck, if you will, with the margins that we're taking. And we're going to wait for this research study before we would think about changing them. What about the lymph node, the sentinel lymph node? What's the recommendation for doing that? Well, we believe that a sentinel node biopsy is indicated for any patient who's reasonably healthy besides their melanoma, that has reached at least 0.8 millimeters thick. That asterisk of 0.8 millimeters is for 2 reasons. One, when we say 0.8 millimeters, the convention today is to just talk about the thickness to 1 decimal place. So 0.8 really means 0.75 and above if the pathologist measures it to 2 decimal places. Okay, 0.75 and above. And we would do this anywhere in the body, pretty much any time. And we would expect that at that threshold, once you get to 0.8 millimeters or 0.75 millimeters thick, you've got about a 5% chance or greater of having a positive node. And that chance is what we think is enough to justify doing this procedure, this sentinel node biopsy, because it provides reliable staging information with relatively few side effects and with very few recurrences in the lymph nodes if the sentinel node is negative. Not only that, if the sentinel node is positive, getting that node out early on seems to be beneficial, and like I said before, decreases the need for lymph node dissections, and that's something that we're all eager to see. Okay, here's an example, some older data, but it's an example of what we get from a sentinel node biopsy. If the melanoma is in that intermediate thickness category of 1 to 4 millimeters, and the sentinel node was negative in this study, over 85% of the patients had survived 10 years with their melanoma. Whereas if the sentinel node was positive, it was only 63%. Couple of things stood out back then in 2014 and still do today. One is that not everybody with a negative sentinel node survived. Almost 15% of the patients, even with a negative sentinel node, had died from their melanoma by 10 years. The other, of course, was that not everybody with a positive node died either. 63% lived 10 years. Some of them were alive and their melanoma was still under treatment and may have not lived a lot longer. We don't know, but many of them were cured just by their surgery. In this study, anyone with a positive sentinel node, anyone on that red dotted line, had a complete lymph node dissection as well as a sentinel node, but still 63% were alive. And, you know, that's pretty good. We would like to use treatments to get that number to be even better, but be that as it may, not everyone who has a positive node dies. Not everyone who has a negative node is guaranteed to survive. So let's talk a little bit more about what that does mean. It still is reliable. I focus on that word because it's not an absolute. It doesn't mean absolutely yes, absolutely no. It's reliable in differentiating high risk from low risk, from allowing us to plan. Do you need treatment? What are the likelihood that the melanoma will come back? Okay. Now, one of the real frontier questions, I think, and we spend a lot of time thinking about it, is do we have to do a sentinel node biopsy on everybody? Are there some patients whose risk is low enough that we could avoid having the procedure? Can't we figure out some way of figuring out who needs the sentinel node biopsy and who doesn't? And I would say that today the answer is no. We don't know reliably enough to avoid sentinel node biopsy in most patients, but we're working on it. And we are actually running a study, which is looking at a test called the gene expression profile. We've now got a number of examples of gene expression profiles that have been developed where a piece of the tumor, a piece of the biopsy that the pathologist has just looked at under the microscope can also be analyzed molecularly, genetically, not just by looking at it, but by analyzing the individual genes and how many and how much those genes are expressed. That profile can be used to develop a signature that says this is the signature of a high-risk patient, this is the signature of a low-risk patient. And that's exactly what we're working on in a large study that is taking 1,820 patients from 9 melanoma centers around the United States, including ours, Mayo Clinic, Louisville, Michigan, number of other places. And every one of those people is having a sentinel node biopsy for standard reasons. And everyone, we're going to say, yes, it was positive or no, it was negative based on the pathologist looking at it. But in every one, we're also taking a piece of the tumor, sending it to the research laboratory and seeing if the gene expression profile of the node positive patients is different than the node negative patients. We'll need over 1,800 patients, as I said. We've got over 1,700 patients entered onto the study, but only about 1,500 have already had their sentinel node biopsy. Others are just getting one. Well, I just did one this evening, so it's 1,470 now that have had their sentinel node biopsy. But the great thing about this study is once that last patient, number 1820, has their sentinel node biopsy and the pathology result comes back, we'll be able to analyze this study and see if there really is a way to predict, at least for some people. And so we're hoping that that kind of analysis could begin as soon as within the next year or so. Now, if you were paying close attention to Dr. Mitchell, you heard that just like I said that not everyone with a negative node is cured, some of them recur. We've recognized that. We try to do something about it. Some people with negative nodes, specifically what we call stage 2B and 2C, or T3B and T4 melanomas, are able to get adjuvant immunotherapy. It's FDA approved. We have 2 studies that show it's favorable in delaying or preventing recurrence. So the question comes up, well, if I get a sentinel node biopsy and it's negative and I get pembrolizumab, and I get a sentinel node biopsy and it's positive, I get pembrolizumab, why don't I cut out the middleman? Why do I need the sentinel node biopsy at all? Why don't I just go right to the pembrolizumab and not have the sentinel node surgery? And it's a very reasonable question. It's one a lot of people have thought a lot about. And here's what we say. We say, yes, you should do it. And here's why. Because knowing what's in that sentinel node, is it positive? Is it negative? Not just is it positive, how much tumor is in that lymph node and how many lymph nodes are involved, gives us a lot of additional information. It may not be information that says, yes, do treatment, no, don't do treatment, but it gives us a lot of information we can use and information that we can benefit from. And here is how that works. Now, these two curves aren't on the same scale because the risk of a negative node, which is on the left side here, is still less than the risk of a positive node. And so what we see is stage 2B or 2C melanoma, which is down here in this red box at the bottom of the left-hand graph. The likelihood of being alive 10 years later between 75 and 80%. Now, this is at the lower end compared to what I said on that earlier sentinel node graph, but remember that was just 1 to 4 millimeters. This is basically 2 to greater than 4 millimeters, all the way up to 10 or 20 millimeters. So this is at the high end of the scale, and sure enough, 75 to 81% alive at 10 years. But if that same patient has a positive node, their chance of being alive at 10 years drops dramatically to as low as 24%, no higher than 60%. Again, 63% on that original study. They were pretty close, but that was all comers. This is a slightly worse group. So big difference, 75% even versus 60%, but surely a big difference between 75 and 25% chance of being alive in 10 years. So that's information. It doesn't change the recommendation, but it's information we might use. Dr. Mitchell stressed how important clinical trials are to get better at all of our treatments, including our adjuvant treatments. Today, we need those clinical trials to test new drug combinations for adjuvant therapy. And today, we need to know that, are you in that 24% or in that 81% group to make that clinical trial meaningful and useful? But there are other reasons we worry about not doing the sentinel node biopsy. The recurrences actually come pretty quickly if we don't do it, within an average of about 9 months. If the person has a node that's positive and we didn't take it out and the immunotherapy doesn't get rid of it, then within a few months after starting treatment, you may already have a recurrence. And then what happens? You need a lymph node dissection right in the middle of all your treatment. And that's what we're really trying to avoid. And I won't go through all the details and all the calculations, but the bottom line is, if we don't do a sentinel node biopsy, we're talking about around a 20% chance of needing a node dissection despite the adjuvant treatment. And if you get the sentinel node biopsy, that number is more like 5%. That's a big difference in your ultimate chance of having a lymph node dissection. And there's one more thing about all these calculations and decisions. That assumes that every single person who has a stage 2B or C melanoma would have adjuvant therapy and would get it. And right now, we don't come close to that. Even for stage 3, not everybody gets adjuvant therapy. Many people choose not to have it. And then these outcomes, these numbers would be even worse. So I'm going to switch gears and talk about where we're heading in surgery for advanced cases to do even fewer lymph node dissections, even once the melanoma is in the lymph nodes. And what we're doing to get beyond adjuvant therapy, because as Dr. Mitchell said, we have to treat everyone with adjuvant therapy to get the benefit of a few, and we never even know who those people are. So some people get the adjuvant therapy, have all the side effects, all the costs, all the inconvenience, and the tumor comes back anyway. They're the people in this blue section of the graph. In the red section are the people who the surgery cured, and they got that treatment for a year and all the side effects and all the costs, and they didn't need it because they were already cured. And the green section is right in between. It's about 20% of the people who really did benefit. Their outcome was changed by the adjuvant therapy, but we don't know which ones those are at the start. We don't even really know which ones they are at the end. It's a big drawback of adjuvant therapy that we have to treat everyone without knowing who we are benefiting. And when we get to stage 2 melanoma treatment, where the initial outcome is better, and so the red area of the people who are cured without surgery is even higher, then we're treating even more people to benefit just a few. So we want to do better. How can we do better? The key is what we call neoadjuvant therapy. We really think this is a better way to use the miraculous drugs that Dr. Mitchell and her colleagues have developed in conjunction with surgery to get better outcomes. Neoadjuvant therapy, many of you have heard of it. It's the administration of systemic drug therapy prior to surgery in patients who have regionally advanced or metastatic disease. They have a lump, it's there, it's not something that is given to prevent it from coming back. It's given while the disease is active, present, measurable, or accessible by scans or measurements or other of one sort or another. And then after several doses to several months of doses of drug, we have planned to carry out surgery, usually in a very specific and defined period of time. We check the response of what we did by clinical exam. We can tell that this tumor is shrinking. We can look at the CAT scan. We can look at the PET scan. And most importantly, when we do the surgery, we look at the cells themselves under the microscope to see if they've been damaged by the treatment. And we can use the information of what that pathology report tells us to decide whether we should continue to give treatment after surgery. Whereas with the adjuvant therapy, it's a year. We're just looking at the calendar. That's the only thing that tells us when it's time to stop is the calendar. With neoadjuvant therapy, we get more information and there's more we can do. So to summarize some of the advantages, we can assess the response to treatment. We can identify some other people who have such resistant tumors that surgery wasn't even worth doing. And there are some disadvantages. Sometimes the tumor could get worse. Sometimes the side effects of treatment could make it difficult or impossible to do surgery. So we had to figure out, was this really a good idea? Was it really worth it? And this trial that was just reported in the last few months really was groundbreaking. It was super simple. Take everybody who had lymph nodes, metastatic melanoma, the lymph nodes hadn't been taken out, not a sentinel node biopsy, but a palpable mass in the armpit or the groin or whatever. All of them get immunotherapy for a year. All of them get surgery, but they're randomized to either get all the immunotherapy after the surgery or 3 doses before the surgery. Everything else is the same except 3 doses before versus all after surgery. Couldn't be more simple of a comparison. And yet that difference was enormous. This study, the first part of this curve shows that before surgery, that's basically the vertical line is sort of the before surgery, and this part of the curve, the horizontal part, is the after surgery. The outcomes were the same, whether it was side effects or whether it was unable to have the surgery because the tumor was worse than we thought. Those outcomes were basically the same in the randomized groups. But once they got through the surgery, the ones who'd had the 3 doses of immunotherapy before surgery are living longer with less recurrence than the patients who had all of their treatment afterward. And it's very early yet to look at actual survival, but already it's certainly favorable for the 3 doses, just 3 doses given in the neoadjuvant setting was enough to improve survival in melanoma and really dramatically. Another study is going on that is looking at a different neoadjuvant regimen, Ipi-Nivo, the combination that Dr. Mitchell talked about. We like that one even better for our neoadjuvant therapy than single agent Pembro. And they're just half the patients get Ipi-Nivo before surgery, the other half get surgery and nivolumab. We'll see if that shows the same powerful results that the SWOG study showed. But the last thing I want to show is how powerful it can be to know what happened to the tumor, to know that the tumor completely disappeared, because 30 to 50% of the time when we operate now, after these 3 or 4 doses of immunotherapy, there's no living tumor left. It's a pathologic complete response, and the pathologist cannot find any living tumor. And if we do that, if we find that pathologic complete response, we don't necessarily have to do a lymph node dissection. We don't necessarily have to continue immunotherapy. And if we find that it doesn't have that, well, we have to really intensify the treatment and maybe even add drugs like the BRAF inhibitors if the patient is BRAF mutant. So today, we are taking our patients who have a positive and enlarged lymph node, and we're placing a tiny marker. This is a magnetic marker on the left side. We use a radar localizing marker here, this thing that looks like a satellite on the other side. And then we only take out the lump after the neoadjuvant therapy and have the pathologist analyze it. And sometimes that's all we need to do. We don't even need to take out all the lymph nodes. We can take out one single lymph node, prove that the cancer has been killed, and stop there. So that is a tremendous potential advance. We're just starting to do it, but we're doing it more and more commonly. And so speaking of stop there, I am going to stop there and let us go on to the next topic. But thanks all of you for joining us at this webinar.
Thank you so much, Dr. Sondak. That was really a great way to describe it in a way that our patient community can understand. And I just have a quick question for you. So when patients are referred to your office, do you have that conversation with them about neoadjuvant versus adjuvant?
Mm-hmm.
And what kind of things do you look at when you're deciding if a patient should go forward with either option?
So the first thing we look at is how much tumor is actually there to measure or to study. Okay, if the person comes in and they said, "Oh, I had this big lump, but they took it out, and now there's nothing there. Should I have the treatment or should I go to surgery?" Well, if there's nothing there, there's nothing that we can tell. We're back in that situation of trying to prevent the cancer from coming back. So generally, that's not the neoadjuvant approach. We're actually treating something. But if they only had a needle biopsy and the tumor is still there, those are the patients we want to look for. So there may be ways in the future we can expand this, but we're looking for people, and it could include somebody, say, that had a sentinel node biopsy and now the melanoma came back in the lymph nodes despite having the sentinel node biopsy. Those are people we would strongly think of for neoadjuvant therapy. Others are people who didn't even know they had melanoma and just show up with a lump under the armpit, and somebody sticks a needle in, oh, it's melanoma. So we are looking for it. We are actively using it in those patients. And although this is a melanoma webinar, also say that we are using it in other forms of skin cancers, squamous cell cancers, Merkel cell cancers in particular, when there are enlarged lymph nodes or very large tumors, we're using neoadjuvant therapy there as well.
Fabulous. Thank you. One last question for you. You started to speak about the future a little bit. What kind of brings you hope when you think about the future of melanoma treatments?
Already, you know, the progress that has been made in the last 10 years exceeded anything I ever expected to see in my entire career. The improvements in the outcome for our patients with metastatic disease and the effects of neoadjuvant therapy. I've said this several times, but literally every week in my clinic, I am seeing at least one person who had neoadjuvant therapy. They're coming in for their post-operative visit, and I get to tell them, guess what? There wasn't a single living cancer cell in your tumor. And I just got another report like that, and it's just amazing to be able to tell people that. So if we could then match that up with a way to tell people you don't even need a sentinel node biopsy, we tested your tumor, you don't need this, boy, we'd really, even if it wasn't everybody, it was only 10 or 20% of the people who are currently having to have a sentinel node biopsy that now don't have to have it, I think we'd be doing something really good. So those are some real exciting opportunities, I think, that are right around the corner for us.
Absolutely, and that's remarkable. Well, thank you for being here with us. I know you're coming straight from the OR, so we appreciate your time and for making it here. We're going to turn to our next speaker. Dr. Wetherick is here with us. Thank you for being here as well. Dr. Wetherick is an associate member in radiation oncology at Moffitt Cancer Center and the section head for cutaneous radiation oncology with clinical and research interests centered around cutaneous malignancies. Dr. Wetherick is the clinical director of radiation oncology at Moffitt Cancer Center, associate chair of graduate medical education at Moffitt, and chair of the NRG Oncology Radiation Oncology Committee. Thank you for being here. I'll turn it over to you.
All right, thanks so much. Let me share my screen, make sure we can all see the slides. There, are you able to see that?
All good?
Excellent. So I was asked to share a little bit on the role of radiation therapy in melanoma treatment. And as I go around talking to people in the clinic and just in like soccer fields and, you know, festivals and things like that, one thing that becomes clear is that people don't really understand very much about radiation therapy. That's not a part of the science or physics that people either didn't quite get to or didn't understand too well. So I'm going to explain a little bit about just what is radiation therapy as a beginning point. And we're going to talk then a little bit about how radiation therapy is used to reduce local recurrence in melanoma. We'll talk a little bit about possible use of radiation therapy to reduce lymph node recurrences. So Dr. Sondak just talked a lot about how less and less surgery is being done. But then there are some people who have a very high risk of a recurrence in that nodal basin, and that's important. And then we'll talk about some of the treatment using very focused radiation therapy to ablate individual melanoma masses. So that could be the treatment of oligometastatic disease, and I'll kind of define what I think that is. And another term, oligoprogressive disease, and we'll define what that is. And we'll talk about also the use of radiation therapy just to make life quality of life a little better. So we're going to hit all those topics during the course of this. So you all probably ask, so what is radiation? What does that exactly mean? That probably happens a lot in clinics. Well, what radiation is that it's part of the electromagnetic spectrum. So you probably have heard, everybody has experience with radios, and you turn the radio to a certain frequency, and what you get is music or political commentary or sports news or something like that, depending on which frequency you have it turned to. And that's because there's these invisible waves that are flowing through the air, and they get broadcast through a tower, and those waves get picked up by the transistor, and they get and that's how radio works. And those waves are very long, have a very long wavelength, and that's why we can get a radio station from 100 miles away. Sometimes even from Tampa, we can get radio stations from Chicago or Philadelphia on a cloudy night. And so we're all real familiar with that. And we're also probably familiar with the next set of electromagnetic radiation, which is the same kind of energy, but the wavelength is just smaller, and that's a microwave. Most of us have a microwave oven. You put your food in there, and it's different than a convection oven, a typical oven, because in a typical oven, the actual oven inside of it is hot. So it heats up your food because the actual box in there gets hot. But in a microwave oven, you put your food in, you press the button, it cooks for however many minutes. But when you actually feel the oven inside, it's not actually hot, because it was the microwaves that were generated by that microwave oven that transmitted that energy to heat up that food. So that's how that works a little differently, right? And so those microwaves are just smaller of those waves. Even smaller waves are infrared light. Most of us have seen some kind of movie or something where the bad guys are found by some infrared special glasses that the military can see or something like that. And so that's just an even smaller wavelength of light. And then there's the light that we can see that goes from red to violet, and that's broken down into the colors, that we learned Roy G. Biv for, red, orange, yellow, blue, indigo, violet. And then Dr. Hartman talked a lot about ultraviolet light, which is the actual light that causes a sunburn, that's the most damaging to our skin, and that exists in an even yet smaller wavelength, and that's a wavelength that we can't see. And then as you move to even smaller and smaller wavelengths of energy, you get to what are called X-rays. And X-rays are generally generated by a machine. And those X-rays can be used either to take pictures of a bone to find out if it's broken, for example, or at its even more energetic state to be focused on a tumor and cause the tumor to die. And we'll talk about how that works. All right. So what happens is that the X-rays come in and they interact with the cell, and they eject an electron from some of the atoms in the cell. And then those electrons go on, because they're unstable, to create oxygen-free radicals. And they actually end up creating damage events to the DNA in the individual cells. So the individual cancer cells are taking on these damage events. And it's estimated that like a typical dose of radiation that's used commonly in the clinic induces up to around 40 double-stranded breaks per cell. So you're basically just creating all these break events in the DNA of the cell. And when a double-stranded break occurs, the cell doesn't repair that very well. And because it doesn't really know whether to, if you think about a string, if you were to cut it in half, you don't really know whether the string belonged to go back this way or like this. And so in the repair process, a lot of times there are mistakes, and therefore those cancer cells get damaged irreparably. And so there are basically 3 different ways to cause this kind of DNA damage. And they're all kind of under the broader title of radiation therapy, but they're a little bit different. So there's X-ray therapy, and that's the most, what I was just talking about, with those very short wavelength electromagnetic energy. And those are the most common kind of, and that is the most common kind of radiation therapy, because it can penetrate deeply into the body and deliver its dose. So a person that's being treated for lung cancer or prostate cancer or esophagus cancer usually is getting treated with X-ray therapy, because those organs, structures are deeper within the body. And so you got to get some penetration into the body and before you want to deliver the dose, and X-ray therapy is the ideal way to do that. Remember, that was electromagnetic energy, so that's kind of energy, but also there are particles. So we all remember that the whole world's made up of different atoms like hydrogen and carbon and nitrogen, oxygen. And those atoms themselves are made up of subatomic particles, so smaller than the atom itself, the composition of the atom, which are like electrons, protons, and neutrons. And so we can use those individual particles also to cause those same DNA damage events and treat cancer. And that's also part of radiation therapy. And so a typical radiation center, they have electron therapy. And electrons, because they're the smallest particles, they just treat things very superficially. So they just treats the skin and the layer of subcutaneous tissue between the skin and the muscle or organ. And so these are very effective for various skin cancers. So we treat a lot of squamous cell carcinomas and basal cell carcinomas with electron therapy. We can also treat, melanoma primaries on the skin with electron therapy. And we'll talk about the situations in which we do that. And then also, just to round out the conversation, there's proton therapy, and proton therapy is available at selected centers throughout the country. I think there's about 40 different proton centers now in the United States. And those have their own benefits, which is that it's a particle, so it stops and doesn't have any exit dose, but it can penetrate more deeply into the body than the electrons can. And then there's neutron therapy, which is currently not used anymore. And then one of the futures in radiation therapy is using heavy ions like carbon ions or helium ions as a potential other kind of radiation therapy. But that's more of a future application. There's a few heavy ion centers that are either being built or are currently. Then the last thing, just to round out the conversation about basic subtypes of radiation therapy, is brachytherapy. And brachytherapy is the idea of bringing an actual radioactive element and sitting it either in, implanting it into the tumor or sitting it right next to the tumor, so that when it decays and it gives off its high energy photon, it will also cause that same DNA damage. And so many people have heard of like a iodine 125, like a seed implant for prostate cancer, where the radiation oncologist will, through a catheter system, implant a bunch of these little grains of rice into the gland, and that will, decay over time over the next several months to deliver the radiation therapy. But we use various different kinds of radioactive elements for different situations. We can certainly talk more about that if there's interest, but that's the basic overview. All right. And we've been treating skin cancers for a long time. So it's been about 120-year experience with using brachytherapy to treat skin cancers. But way back when, they were just sort of figuring out all these different radioactive elements, and it was treated in 1903 using radium salts. So, okay, and so the way that radiation therapy is given is a little complicated, but if you understand why, then it starts to all make sense. So what you're trying to do with radiation therapy is you're trying to take advantage of the fact that tumor cells, as that melanocyte changes into a melanoma, as it goes through that metamorphosis and changes, almost all tumors one of the things that they do is they start to create many more proteins for cell division and for things like invasion. And therefore, they make many less proteins for the normal cell repair and maintenance. So you got these normal healthy cells that are pretty good at repair and maintenance, especially as adults. We spend most of our time just ourselves doing repair and maintenance. We don't actually grow a ton of new cells. Yeah, we grow new skin and new bowel cells, but most of our cells, muscle, nerves, and things like that, the cell number stays about the same. And so you have those cells that have lots of repair and maintenance machinery sitting next to tumor cells, which have a relative lack of those repair and maintenance. So what you do is you create this DNA damage. Those normal healthy cells are able to repair themselves by and large. Tumor cells have much less repair capacity. Then you hit them again the next day. A lot of repair by those normal healthy cells, not much by the tumor cells. Then you do it again. And you can see how as you keep doing this, you're going to get a fairly minimal change to those normal healthy cells that are repairing themselves along the way, versus enough damage to the DNA of those tumor cells that it ultimately leads to them dying. And so that's the whole strategy of radiation therapy. And taking that whole dose of radiation that you give somebody and breaking it up into smaller doses is called fractions. They're because they're fractions of the whole dose. And they first realized that this was important back in the 1920s and 30s with a series of experiments, actually, where they, instead of treating cancers, what they wanted to do is they wanted to sterilize farm animals so that the bulls and the rams wouldn't, cause havoc, get their horns caught into thickets and hurt themselves and things like that. And so they wanted to sterilize farm animals. And so they realized pretty rapidly that if they gave a big dose of radiation all at once to one area, that they could sterilize the animal, but that they'd get a whopping red skin burn and reaction, and it was no good. They'd get an infection, and it would put the animal's life in jeopardy. But if they use too low of a dose, they wouldn't get sterilization. But if they use that same low dose, but over many doses, they could achieve this sort of happy median where they could achieve the sterilization that they were looking for, but not actually hurt the animal. And so that's sort of how these fractions of radiation therapy was sort of discovered back now almost 100 years ago. And what we find today is that there's a wide range in the sensitivity in human cancer. So some cancers like lymphomas, small cell lung cancers, leukemias, other things are very sensitive. There are other things that are things like colon cancer, glioblastomas, and actually more melanomas are more on the less sensitive to radiation therapy side. Okay, but some melanomas are certainly very radiation resistant, and so we try to use bigger doses of radiation therapy for melanoma compared to things like prostate cancer, breast cancer, in which smaller doses are used more commonly. And so just like Dr. Sondak was talking about trying to predict ahead of time which patients might benefit from sentinel lymph node biopsy or which patients might benefit from immunotherapy, a great holy grail of radiation oncology is to try to figure out and predict ahead of time which cancers will be the most sensitive to radiation versus which ones will be relatively resistant. All right. I'll go briefly through this just for the interest of time, but this was just to make the point that even back in the era around World War II, it was becoming clear that you could treat patients with melanoma and get a response from radiation therapy. In fact, they just called it a black nevus at that point, but it was probably a melanoma. First record of treating one successfully was in 1913 with radiation therapy. But it doesn't work reliably enough, and so that's why surgery still is the main treatment for most patients with like just a localized melanoma. But in the 1980s, what they realized is that some of the really big melanomas that were very aggressive looking under the microscope and had aggressive features, when they used both surgery and radiation therapy together, they could achieve really good control rates. And this is some of the data from MD Anderson, where they used surgery and then they used postoperative radiation therapy afterwards. And this led to many more clinical trials and investigations in the 1990s and 2000s to better define radiation therapy's role in melanoma. And so where we're at now is that surgical resection still remains the mainstay of local therapy. And for most melanomas, the risk of a recurrence locally, like right near the incision site, is pretty low, around or less than 5%. But there are some features that bump that likelihood of local recurrence up. So very thick melanomas are more likely to recur, somewhere between 6 and 14%, depending on which study you look at. Those in the head and neck seem to be more likely to recur compared to those on body sites. That's mostly because probably the surgery is a little more skimpy in the head and neck, right? Because if you're trying to take out a melanoma on the cheek, you're more sensitive to cosmetic concerns, so you might have smaller margins. An ulcerated melanoma is more likely to have a local recurrence. Those that have the satellite lesions are more likely to have a local recurrence. And then, as was discussed by Dr. Hartman, that there's a subtype of melanoma called dysplastic melanomas, and they seem to be more likely to have local recurrence. And so at Moffitt, we undertook a large retrospective review of all of our desmoplastic melanoma patients and realized that there was a pretty big difference in the local recurrence rates among those patients that had radiation therapy after surgery versus those that just had surgery alone. So we're looking at the difference between about 24% and 5%. And here's how those curves sort of look as far as, local control here is on the y-axis and time is on the x-axis. And you can see that those that have surgery alone have a higher risk of having a local recurrence. Another way to look at it is to break down the patients and say, okay, if you have a positive margin after surgery, the risk of recurrence is about 80% without radiation therapy, but radiation therapy can reduce that down to somewhere in the 10 to 15% ballpark. And then we also looked at those that had negative margins and also showed that for most patients, there's a benefit to postoperative radiation therapy. So with that information, we think that the indications for having radiation therapy to the primary, like to that actual skin that harbored the melanoma after surgery, are somebody in which we couldn't get negative surgical margins. So a case in which, like Dr. Sondak or one of his colleagues, the tumor was butting up against some sort of critical organ, or the reconstruction was going to be very difficult. And so there's a positive surgical margin. And then a desmoplastic subtype. So there's this rare subtype of melanoma that's about 2 or 3% of all melanomas, tend to occur more on the highest sun exposure areas, so scalp and forehead. That particular kind of melanoma has a much higher risk of a local recurrence. And so we offer postoperative radiation often to those patients. And then we sort of consider doing postoperative radiation for patients that have this feature of perineural invasion. That's another thing that Dr. Hartman talked about that you can find on the pathology report. And there are many retrospective reviews that kind of link perineural invasion with a higher risk of local recurrence. We also think that it's worth thinking about doing postoperative radiation in patients who had a prior local recurrence. Like, let's say you had a melanoma on the arm, it was excised several years ago, and then it recurred right there on the scar, despite a good surgery the first time. Obviously, we expect it to be surgically excised again, but then we consider doing postoperative radiation in those cases. And then sometimes also in cases where the pathology report reports a lot of satellitosis, because that could make if you think about it, if there's a lot of little nests of tumor cells around the main, you may have negative margins, but that may just be because there's one nest on the outside that, doesn't go right up to the edge, but that actually still remains. And then shifting gears a bit, this is a trial that looked at doing postoperative radiation after a node dissection. So this is in patients like with stage 3 melanoma. Let's say this is one that underwent a node dissection, had a lot of high-risk features, and this is a good prospective clinical trial that showed that patients that have high enough risk features can benefit from radiation therapy to reduce the chances of recurring in that lymph node basin. So the challenge with this study is that it's getting a little old now, and it was really done in the era before most of the effective immunotherapy drugs. And so it's not clear whether these same benefits are really true in patients that are getting immunotherapy or not. So we use this data as a really good piece of data for people who can't get immunotherapy for whatever reason, but it may not be as useful data in people who can get immunotherapy. But here's basically our algorithm for which patients are high enough risk to be considered for nodal radiation therapy. And you can see how it breaks out depending on where these lymph nodes are. So neck versus axilla versus groin. And one of the reasons why these indications are a little different is because one of the major downsides of both surgery and radiation therapy to the nodal basin for melanoma is the potential risk of lymphedema. And so lymphedema is important, but usually not, but is usually more tolerable when it's arm lymphedema. However, leg lymphedema can really change someone's mobility and really change their life. So we're a little more strict on the criteria for radiation therapy to groin and pelvic lymph nodes. And then I want to mention a couple other ways that radiation therapy here, as a way in closing, a couple other ways that radiation therapy can impact melanoma. So we also treat a lot of oligometastatic disease. What that means, oligo means like several. So if a person, and that's in distinction to someone who has disseminated or widespread metastatic disease. So disseminated or widespread metastatic disease maybe would be somebody who has 6, 7, 8, 9, 10 different spots of melanoma in different parts of the body, versus somebody who maybe has one lung metastasis. And so in patients with a small amount of disease like that, we have been using focused radiation therapy like on that lung metastasis to eradicate it. And that's a very effective therapy. Now, it doesn't change the fact that that person could develop other spots of metastatic disease at some point in the future, but there is pretty good surgical and radiation therapy data to suggest some benefit to this strategy. And then there's another term that I use called oligoprogressive. And what I mean by that is that if somebody is on an effective systemic therapy, like they're on BRAF MEK inhibitors and it's working, or they're on immunotherapy drugs and generally it's working, but they have 1 or 2 areas where the tumor is starting to grow again, that's a potential area for either surgical resection or ablative radiation therapy. And so that's another circumstance in which we might use something like that. And then there's palliative radiation therapy, which is when metastatic disease is causing symptoms that are reducing the quality of life, and you come in with radiation therapy to that bone or to that area of the liver, or there's all different kinds of scenarios for this, and to try to shrink that local tumor there to make life, to improve quality of life. Like I said, in radiation oncology, there's a growing body of literature that doing this kind of focused radiation therapy for a small volume metastatic disease can be beneficial. This is one randomized study that was done in Canada that was very thought-provoking, because it was about a 100-patient study, and they randomized patients to either getting the standard of care systemic therapy that they were going to get, or they got the standard of care systemic therapy that they were going to get, but they also got this focused radiation to 4 or fewer sites. And what you can sort of see there is that the folks that did get the addition of the focused radiation therapy seem to have better survival rates and better median survival. So there may be something to this treatment of small volume metastatic disease with radiation therapy. Where might we do this kind of ablative radiation? Well, really a lot of places. There's increasingly, more and more places as our technology gets better that we can go. So lung, liver, small, brain metastases, metastases to the adrenal gland or to vertebral bodies, so bony sites, and then really selected other sites, sort of depending on how close nearby a important organ that we got to keep dose off of really is. And then palliative radiation therapy can really be used anywhere in the body, and it, like we said, can be used to treat pain or bleeding, or really any other kind of symptom that is causing a reduction in quality of life. So with that, I'm going to end my formal presentation. Super enthusiastic to take any questions.
Great, thank you so much. A question that we received was about how you decide, and this might be complicated and patient specific, but how you decide how many rounds, or I think you said fractions of radiation treatment. How you decide that for a patient.
Right. So the decision about how many fractions, so usually radiation therapy, usually radiation therapy is given in a single course to a single site. So we usually don't, there are some occasional exceptions to this, but we usually don't go back and treat the same site multiple times. We usually do one course that's a definitive length of time. And exactly how many doses are given for that course is dependent on a few things. It's dependent on how sensitive that particular cell type is to radiation therapy. Like, do you need to give it bigger doses to get a response, or can you use more intermediate doses to get a response? And it also depends on what the goals of care are. Do we really want to kill? Is it imperative that we kill every single tumor cell? In which case we might use a higher dose and more total doses. Or if we killed 90% of the tumor cells, is that going to be good enough to get the desired effect? So let's say somebody has like a mass in their stomach that's bleeding. If we kill 90% of the tumor cells, we're going to stop that bleeding, and then they can get onto their systemic therapy. So 90% is going to be good enough in that scenario, in which case you can usually use less total dose. And then the third sort of major factor is which healthy organs are nearby or in the way, and what kind of doses can they take. And so all of those factors are really used together to try to figure out what the best dose and fractionation is for every situation. I can say that in general for melanoma, because melanoma tends to do better when we are able to give it a little bit bigger dose per day, we tend to use less total doses in melanoma. Like a prostate cancer radiation regimen might be 35 or 40 fractions of radiation given each day, Monday through Friday. But a melanoma regimen is rarely like that. It's much more common that we give somewhere between 5 and 10 total doses, maybe not even on every weekday. We may stagger it, 2 or 3 doses per week, because we're giving such a big dose at that one particular day. Did that make sense?
Yes, thank you. And this is recorded, so if anyone needs to rewind and kind of understand the material on a slower pace, you definitely can. So we appreciate that. And I guess my last question, and it can be for anyone here, is kind of talking about the multidisciplinary team approach. because we heard from lots of different disciplines tonight, and we know that melanoma treatment is very involved. So can anyone speak to kind of what that's like working from that team, patient-centered approach?
Vern, I nominate you because we've really set up a pretty impressive, I think, multidisciplinary clinic, and you've been the leader of that. So I think this one's yours.
Well, I thank you, Evan, and absolutely, the only way to get the maximum benefit of all of the advances that we have is when everyone has a chance to weigh in. So we are very fortunate at Moffitt. We have, when I'm in clinic on Wednesday, Dr. Wuthrick is sitting just a few seats away from me. I have a plastic surgeon sitting next to me who does reconstruction, but also does head and neck skin cancers as well. And just down the way is a medical oncologist, Nikhil Kushalani, and we are constantly interacting, sharing patients, saying, take a look at this, and what do you think? Should we do radiation? Should we do immunotherapy? Should we do surgery? What's the next thing? That and the tumor board type of discussions where everyone weighs in to make sure we haven't missed something are, we feel, the best way to get the maximum benefit in complicated cases. Having said that, many cases are very straightforward and don't need 3 different specialists. They just need an operation, or they just need some immunotherapy. But having access to the team, I think that's what's important.
Yeah, does anyone want to add to that?
Well, just from a radiation oncologist perspective, that kind of collaboration is really important because there are a lot of times when we see patients before their operation, and then we can kind of see what tissue has been rearranged, and that helps us to understand what tissue is at risk of a recurrence. And if all you see is the end product, sometimes it's hard to reconstruct exactly what happened during the surgery. And so that's another way that I find our multidisciplinary clinics to be very important, because it allows just very easy dissemination of information. Can have the surgeon describe to me exactly what happened during the operation. And, like most things, sort of a picture and descriptions are worth, 1,000 text messages or whatever.
So true. It's all about communication. Well, wonderful. Well, we've come to the end of our program, and I want to thank you all for taking this extra time out of your evening, out of your day, to be with us, away from your families. So I want to make sure everyone gets back to their families and to dinner. But I just want to say that we will be having 7 more cutaneous patient and caregiver symposias all across the country in 2024. So look out on our events page on where we're coming, because hopefully we're coming to a cancer center near you. Hope I don't sound too much like a commercial, but we will be in a bunch of cities next year. So I hope to get to know all of you in person and get to continue to create community and provide educational opportunities. I just want to again thank our speakers and appreciate all that you do for the melanoma community every day. And again, for taking the additional time this evening. This program will be available online in our learning platform on melanoma.org, and also streamed to our social media channels. So make sure you follow us there. At the end of the program, when you close out of Zoom this evening, an evaluation link will come up, and feedback is so important to us when we plan these type of events, so that we can provide further programs and educational opportunities for this community. So please provide us with any feedback on today's session and future sessions that you're looking to see. Again, visit us at melanoma.org to learn more about our upcoming webinars. We do one each month, and other educational or advocacy opportunities. If you have any questions for me, you can reach me at education@melanoma.org. Or if you have any follow-up questions from tonight's session, please feel free to reach out to me. Again, it's education@melanoma.org, and it's in the chat box for you. And have a good evening. Thank you everyone for joining us. Take care.